I want to talk about readiness criteria for DBT PE. So there are 6 readiness criteria that we want to think about when we are trying to make the determination around whether or not a client is ready to do DBT PE. I really encourage you all to consult your DBT teams when making some of these determinations, because only one of the 6 criteria is objective. The other 5 are subjective. So it is not always a slam dunk where it's like, yeah, this person is ready, or yeah, this person isn't ready. So with Adriana, one of the things that was really challenging was she was totally ready to go until she very quickly wasn't. And so as we were sort of reconsidering her readiness criteria following the suicide attempt, what the therapist was really considering was what happened, right? What was the chain to the attempt? What were the cues? What were the emotions? And is this all either no longer happening or sufficiently under control so I, your therapist, feel like I can embark on this exposure-based protocol with you? So the very first thing, the very first criteria is not an imminent risk of suicide. That was met. The target start date became September 1st, 2023. There was nothing to target at that point. Client had recommitted. Number 2 was no suicidal or self-injurious behavior for at least 2 months. So because she had the suicide attempt in the middle of May 2023, the earliest possible start date would have been mid-July. That is the one objective criteria. Because the target start date was September 1st, this was met. Number 3 is that clients have to be able and willing to control urges for suicidal and self-injurious behavior when in presence of cues. So essentially what this means is we want to make sure our clients aren't just white knuckling it. So we really looked at what are Adriana's cues for suicidal and self-injurious behavior, and what do we need to see that she can do. So a couple of things. Number 1 was feeling like she needs to demonstrate that she can feel invalidated by her mom without engaging in suicidal ideation or other maladaptive escape behaviors, such as dissociation, sleeping meds, isolating. And both similarly but differently, she also needed to demonstrate that she could tolerate going to couples counseling where they were really focused on Mark's affair, also without engaging in suicide planning or other maladaptive escape behaviors. So what they came up with was a few things. There had to be kind of at least 2 conversations with mom and following on the skills plan, and then 2 months of couples counseling. Like 2 full months, weekly couples counseling with targeted focus on rebuilding trust, which was the client's stated goal. And Mark needed to attend a joint support session before starting DBT PE with client's therapist. So that was sort of the plan that was in place. Because learning about the affair had been the thing that prompted the suicide attempt, therapist was not going to start DBT PE until there was enough data underfoot that the client could tolerate talking about this affair without engaging in suicide planning. So 4th criteria, so we've kind of hit life-threatening. Now we're on therapy interfering. So there can't be any serious therapy interfering behavior. For a variety of reasons, but fundamentally, if a client is engaging in a ton of therapy interfering behavior, the treatment is unlikely to work, right? Exposure is a high frequency treatment. We are bringing DBT PE into the context of DBT. So the clients that I work with typically are still in standard DBT. They're getting DBT time. They're getting DBT PE time. They're often still in group. And so if a client is canceling a lot of sessions or they're not doing homework, they're just not getting enough dose of DBT PE. And I don't want to put painful cues in front of a client week after week if they're not actually going to get that relief between sessions. So for Adriana, it was no late cancellations, and the not calling for coaching when needed was a real problem. So the parameter they put in place is that they needed to see 1 month of attending all individual and group sessions, which was, 2 times a week. If Adriana needed to cancel, she had to do it at least 48 hours in advance, and the session needed to be rescheduled the same week. And then the therapist requested 1 month of weekly coaching calls explicitly where Adriana was labeling the problem, labeling her emotion, labeling the skill she already tried, and most importantly for this therapist was asking for help. The behavior that the therapist was trying to shape for Adriana was saying, hey, I really need help. Because historically, sometimes what would happen, Adriana didn't reach out for coaching much, but there were a few times she'd text the therapist and say, I'm having a really rough time, or I'm really struggling. And then the therapist would kind of go, well, I don't really know what to do with that. It's not an explicit request for help. So really getting Adriana used to saying the words, I need help. So then number 5, again, going to quality of life. PTSD is the client's highest priority goal, right? And it was at this point, right? It was so clear to Adriana that PTSD needed to be treated, and she was fully on board. And then number 6 is ability and willingness to tolerate intense emotions without escaping. So to be honest, this is the one for me that I feel like is often trickiest to assess. It's also the one people occasionally forget about. I think sometimes clinicians really are focused on the suicide and self-harm criteria and overlook the emotional experience criteria. And exposure is hard, right? We're blocking avoidance. We're having clients talk about really emotionally evocative situations and then sit and tolerate and process their emotional experiences. My DBT clients, my DBT PE clients typically come to me as expert emotional avoiders. So my job in all of stage 1 is to get these clients who often come to me using maladaptive exposure strategies. I have to help them learn how to adaptively avoid. I have to help them learn how to practice opposite action. I have to help them learn how to do mindfulness to their emotions. I have to help them with some informal exposure to their emotions before I even get to DBT PE. And so really thinking about like my own progression of emotional experiencing in session as being so key, because I need my clients, it doesn't have to be perfect, right? They still have PTSD, but I need them able enough, like 20, 30 minutes to be sad, to feel shame, to feel anxious, to feel angry without trying to shut those emotions down. So Adriana could do this, and it was intermittent. And part of it was, the reason it was intermittent was like when vulnerability was high, the willingness just kind of wasn't there. Like the skill was on board, but if she had a fight with her husband or was having a rough day, sometimes there was this like, ugh, I just want to go to bed, right? And so the deal was for the therapist, they were going to continue to practice mindfulness to current emotion, both in and out of session with a variety of targeted assignments.